There has been an increasing trend on knowledge with regard to the transgender movement, and this creates an avenue for education and information dissemination, not only for our transgender sisters but the general public. However, it should be noted that there are very limited studies on transgender individuals, and with the limited studies present, the prevalence of male to female transgender persons was pegged at 1 is to 30,400 to 200,000 by a study done by Alice Lager and Conway in 2007, and this number is believed to be underestimated. This is also evidenced by the increasing number of transgender persons seeking care. So, in an effort to educate and share a medical perspective on transitioning, for this Transpennine Summit, I would like to present Healthy Transitioning, the Medical and Surgical Perspective. My name is Dr. Berina. I'm a trans woman and a plastic reconstructive and aesthetic surgeon from Southern Philippines Medical Center. Let me begin first by saying that transitioning is a process and should begin with self awareness. I would like to debunk the idea of some of our transgender sisters who would want to transition all at once. Transitioning is a process, it is not a one way stop, that everything should be done at one go. And this will always begin with your self awareness. This is firmly grounded on the idea where the transgender movement is anchored on, which is self determination. We have the right to determine the things that we need to do for our body. And medically, this is anchored on the principle of autonomy, wherein we let the patient decide for themselves. So, as much as we cannot out people, we cannot also force people to transition if they don't want to. My objective for this afternoon's talk would be to discuss the basic differences between a male and a female body, to give an overview on the basics of transitioning, and to reiterate the dangers of self-medication. I would like to also to introduce the W path protocol for transitioning, and to give an overview on hormonal replacement therapy and rundown on surgical procedures that is done for transitioning. Let me begin by just showing you the difference between our bodies. In general, there's really stark differences between the body of a male and a female. We can say that the males have much larger muscle mass, bone density. Males are taller. They have bigger body parts, like for example, bigger hands, bigger foot. Um, they have wider broader shoulders as compared to women. Females have a more slender neck with less prominence of the trapezius muscle, which can be seen here. If you're going to look at the back of a female, you can see like there's a letter V that forms with the from the shoulder going to the center of the intergluteal line here. The narrowest part would be your hip, and that would the waist, and that would broaden to form the hip here, with a very less prominent lateral hip depression as compared to a male. Females also have a more rounded buttocks, meaning there is actually more equal fat distribution along the four quadrants of the buttocks. Aside from the stark difference of having, of course, breasts and the genitals, these are the usual differences we see between the male and the female body. And with regards to the face, in a systematic review done by Morrison et al. On facial feminization, and this came out in the Journal of Plastic Surgery, we can say that they said that the difference actually between the faces of a male and a female is firmly anchored on the differences in their skeletal structure. And this has been summarized here, wherein the difference between the skulls, faces, and neck of a male and a female, the males would usually have square-shaped face, while the females have oval-shaped face. In general, the males have a sloping forehead, pronounced brow ridge, and deep-set eyes. Also have high cheekbones, large mouth, and large dental arch. The males also have longer neck, and larger skulls with a taller angular lower jaw. So that makes their face square. While females have a vertical forehead, you can see it here, with a more rounded, smooth forehead with forward set eyes, low cheekbones and less prominent, small mouth with small dental arch. You have a shorter, thinner neck and smaller skull. The lower jaw is shorter and tapered, which makes the jaw more V-shaped. Hence, that's the V-shape ideal aesthetics that are being sought by a lot of our transgender sisters out there. So in general, the male facial features are larger and widely spaced on the face. They have larger trachea, and of course, the presence of Adam's apple is also evident. While for females, they have smaller facial features, and the facial features are closer together in the center of the face. And these basic differences are actually our basis for surgical intervention when the patient needs or wants to have surgical procedures done on their bodies. So according to the National Center for Transgender Equality, in order for us to have an idea of what is transitioning, you just have to understand the different concepts. When you say transgender, it is a person whose gender identity is different from the gender they were thought to be when they were born. And their gender identity is their internal knowledge of gender. So what happens for transgender persons is that their gender identity does not coincide with the gender they were thought to be when they were born or their sex. Gender expression is how a person presents their gender on the outside, often through behavior, clothing, hairstyle, voice, or body characteristic. And when we say that someone is in transition or transitioning, it is when a person begins to live according to their gender identity rather than the gender they were thought to be when they were born. I would like to say this is my basic tip for transitioning. These are actually intangibles, but someone who wants to transition should have number one, self-awareness and reflection that they would indeed want to go ahead and do transitioning. You must have good emotional support, maybe from your family, from your friends, from your peers, from from your transgender sisters. And number three, which is actually the most important, is you should have the maturity and the willingness to undergo changes in your body. And sometimes it might be disturbing to some what are the physiologic changes that may occur when you go for transitioning. And I would want to, if ever I'm going to advise patients for medical transitioning, I would want them to be willing to undergo these changes and mature enough to understand these changes. But then again, this comes with a disclaimer that transitioning is not a requirement and not for everyone. Saying this, this is just to say that what is in between your legs does not really define your gender. So for some people, maybe in their reflection, they're in their self-awareness, they're already happy with the body that they have. Transitioning may not be a requirement for them, but that doesn't make them less of a trans woman. So transitioning is not a requirement and not for everyone. Which brings me to my next question. Who are then qualified to undergo medical and surgical transitioning? The WPATH, or the World Professional Association for Transgender Health, has come up with a manual or standards of care for health of transsexual, transgender, and gender nonconforming people. This is already on their seventh version. And according to them, medical and surgical interventions are warranted specifically for patients who experience a sense of gender dysphoria. And when we talk about gender dysphoria, this is a discomfort or distress that is caused by discrepancy between a person's gender identity and that person's sex assigned at birth. So currently now, we have treatment available to assist people with such distress to explore their gender identity and find a gender role that is comfortable for them. And treatment should always be individualized. The DSM 5 is a criteria that is being used by is a the manual that is being used by psychiatrists in order for them to diagnose people with gender dysphoria. And the DSM-5 defines gender dysphoria in adolescents and adults as a marked incongruence between one's experience or expressed gender and their assigned gender, lasting for at least 6 months and manifested by at least two of the following. So the patient should have a marked incongruence between one's experience and expressed gender and primary and or secondary sex characteristics. You have a strong desire to be rid of one's primary and or secondary sex characteristics because of your marked incongruence with one's expressed or experienced gender. You have a strong desire for the primary and or secondary sex characteristics of the other gender and a strong desire to be of the other gender. You also have a strong desire to be treated as the other gender and a strong conviction that one has a typical feelings and reactions of the other gender. So two or more of these criteria should be present in order for the psychiatrist to diagnose you have gender dysphoria. For children, there's slight difference, namely, the child should have a strong desire to be of the other gender or an insistence that one is the other gender. In boys, if that is your assigned gender, there's a strong preference for cross-dressing or simulating female attire. Or if in girls, there's a strong preference for wearing only typical masculine clothing and a strong resistance to the wearing of typical feminine clothing. The child should have a strong preference for cross-gender roles in make-believe play or fantasy play. So we can remember during our time when we were still kids, sino yung gusto maging Sailor Moon kaysa maging Tuxedo Mask? So something like that. So also the child should have a strong preference for the toys, games, or activities stereotypically used and engaged in by other gender. In boys, if that's your assigned gender, there's a strong rejection of typically masculine toys, games, and activities, and a strong avoidance of rough and tumble play. And in girls, if that's your assigned gender, a strong rejection of typically feminine toys, games, and activities. The child should have a strong dislike of one's sexual anatomy and a strong desire for the physical sex characteristic that match one's experienced gender. So two of these criteria, if fulfilled in a child, the psychiatrist may be able to diagnose gender dysphoria. And this condition should be associated with clinically significant distress or impairment in social, occupational, or other important areas of functioning. However, gender dysphoria may not be the presentation of gender dysphoria might be different with among people. Some people might experience very extreme gender dysphoria, like the ones that were outlined in the criteria for diagnosing gender dysphoria. Some would feel some form of distress, but not so much. But all of these patients may benefit from medical and surgical interventions. In a nutshell, the W-path protocol for transitioning are as follows. Ideally, the patient should first see a psychiatrist for a psychiatric consult just to prove or just to be diagnosed with gender dysphoria. And then a referral for hormonal therapy may be given. The hormonal therapy may be initiated by an endocrinologist with a strict adherence to pre-treatment and pre-treatment safety with proper assessment of the health status of the patient, at the same time baseline laboratories, and also monitoring laboratories should be done every so often if the patient will be started on hormone replacement therapy. Now, if the patient wants to have a more permanent change in her body, then a referral for surgery can be done to a plastic surgeon, and the different surgical procedures that can be done for the patient will be discussed later. The different options for psychological and medical treatment of gender dysphoria are you have changes in gender expression and role. You can do hormone therapy to feminize the body, surgery to change primary and or secondary sex characteristics, and you can also do psychotherapy. While for social support and changes in gender expression, we can have an in-person or an online peer support resources, groups or community organizations that provide avenues for social support and advocacy. And I think STRAP has been doing a very good job in providing this for transgender sisters in the Philippines. You can also have in-person and online support resources for families and friends, voice and communication therapy to help individuals develop verbal and nonverbal communication skills that facilitate comfort with your gender identity, hair removal through electrolysis, laser treatment, and waxing, breast padding, genital tucking, padding of hips or buttocks if needed, and changes in name and gender marker on identity documents. Hormonal therapy is actually partially reversible, and we have a criteria for giving patients hormone therapy, and these are the following. If they have number one, persistent, well-documented gender dysphoria, capacity to make a fully informed decision and to consent for the treatment, and if the patient is an age of majority in a given patient, if the patient is a minor, then a psychiatric consult that certifies the patient having gender dysphoria would suffice. If there is a medical or mental health concern with the patient, they must be reasonably well controlled. And these are the effects of having hormone therapy. You have body fat redistribution, you have decreased muscle mass and strength, you have softening of the skin and decreased oiliness, decreased libido, decreased spontaneous erections. Male sexual dysfunction is really variable. Some will have it, some will don't. Some won't have the male sexual dysfunction. Breast growth will start at probably at the third to the sixth month while you're into the feminizing hormones. You have decreased testicular volume, decreased sperm production may be variable, thinning and slowed growth of body and facial hair will be evident in the 6 to 12 months. And male pattern baldness might be stopped if you are in feminizing hormones. For our hormonal regimen, we usually just give a combination of estrogen and an anti-androgen. And an estrogen is the female hormone. It can be in the form of oral, transdermal, or intramuscular. However, in different studies recently, oral estrogen, ethinyl estradiol, increases the risk for venous thromboembolism. And sometimes the risk for VTE increases if more than physiologic levels are being taken in. I have some friends who would want to have OCPs or oral contraceptive pills and being taken simultaneously with an intramuscular estrogen. If sobra-sobra na ang estrogen, it might not be healthy because the increase in the levels of estrogen that is not physiologic now for a woman might increase the risk for venous thromboembolism. And venous thromboembolism is a very dire complication of using this. This predisposes you to forming little embolus or blood clots on the deep veins of your leg, and then it can be thrown off going to your lungs that can cause pulmonary embolism. If pulmonary embolism, it is one of the fastest way to die, actually. So there is an increased risk if estrogens are taken in excess. Hence, that is why we don't want people to self-medicate. Another drug that we use simultaneously with estrogen is to have an anti-androgen or anything that would block the already present testosterone in your body. And we have different kinds of anti-androgen. You have spironolactone, which is actually an antihypertensive agent and inhibits testosterone secretion. But the problem with spironolactone is you can have increased potassium levels or hyperkalemia. And when you have hyperkalemia, it can predispose you to cardiac arrhythmias. So kung take ka ng spironolactone, tapos without checking your potassium levels, baka magkaroon ka ng mga problems with your heart. Okay. Cyproterone acetate is a progestational compound with anti-androgenic properties. This is actually not approved in the United States because of potential hepatotoxicity. It can be toxic to your liver, but it is used widely used elsewhere. And this cyproterone acetate is marketed as Androcur. So there's a hepatotoxic or uh, hepatotoxic effect or toxic to the liver if taken wrongly. GnRH agonists are neurohormones that block the gonadotropin-releasing hormone receptor, thus releasing the release of follicle-stimulating hormones and luteinizing hormones. So this is actually a more uh, um, blockade of the um, gonadal blockade. However, this is actually very expensive. So a lot of these are not really readily available for us also. 5-alpha reductase inhibitors are like finasteride and dutasteride. These are they block the conversion of testosterone to the more active agent, which is 5-alpha dihydroxytestosterone. So they have beneficial effects on the scalp, hair loss, body hair growth, and sebaceous glands. And this is actually also used for prostate problems. These drugs are used for prostate problems. Now, with regards to progestins, there's actually no proven difference if you take progestin or not. Now, with the added effect of depression, weight gain, and lipid changes when you take progestin, the WPATH does not recommend the use of progestin when you do your hormone replacement therapy. Progestin, especially medroxyprogesterone, are also suspected to increase the risk of breast cancer and cardiovascular risk in women. With the following, we are, as medical professionals, we are advocating not self to not do self-medication because there are really inherent risks in doing and taking in drugs. And the risk for doing HRT are number one, you have increased risk of when you take in feminizing hormones, you have increased risk of developing venous embolic diseases. You can have more gallstones, elevated liver enzymes, weight gain, and hypertriglyceridemia. So if you have an inherent problem with your triglycerides, doing feminizing hormones at wrong dosages can just trigger this problem. Cardiovascular disease, you have likely increased risk if other factors. You can also develop hypertension, hyperprolactinemia, and prolactinoma. You can have type 2 diabetes. There's possible increased risk with presence of additional risk factors. With regards to breast cancer, there's really inconclusive studies with regards to that. But in theory, taking in exogenous estrogen can increase the risk of developing breast cancer, even for males. And male breast cancer is a reality. Male breast cancer happens 5% of the time. For surgical interventions, these are actually irreversible because we're going to change the body with surgery. And surgery, particularly genital surgery, is often the last and the most considered step in the treatment process for gender dysphoria. While many transsexual, transgender, and gender non-conforming individuals find comfort with a gender identity, role, and expression without surgery, but for many others, it is still essential and medically necessary to alleviate their gender dysphoria. Now, surgical interventions, those patients who develop severe distress, they can have relief from gender dysphoria with the modification of their primary and or secondary sex characteristics because they would want to establish greater congruence with their gender identity. Now, moreover, the surgery can help also patients feel more at ease in the presence of sex partners or in venues such as physicians' offices, swimming pools, or health clubs. And in some settings, the surgery might reduce the risk of harm in the event of arrest or search by police and other authorities. So when we talk about male to female surgical procedures, these are just some of the examples. Usually, it is heralded by doing breast or chest surgery like augmentation mammoplasty with the use of implants and lipofilling. Genital surgery may involve penectomy or removal of the penis, orchiectomy, removal of the testis. Vaginoplasty, clitoroplasty, and vulvoplasty would be in the creation of the vagina, clitoris, and then the vulva. While some non-genital, non-breast surgical interventions would include facial feminization surgery, liposuction and lipofilling, voice surgery, thyroid cartilage reduction, gluteal augmentation using implants or lipofilling, hair reconstruction, and various aesthetic procedures. For breast augmentation, our criteria for patients undergoing breast augmentation would have to have persistent, well-documented gender dysphoria, the capacity to make a fully informed decision, age of majority in a given country, and medical or mental health concerns well controlled. Then we can let the patient undergo breast augmentation. This is just an example of a breast augmentation. This is not my patient, but this is just a sample from the internet. So there are different decisions that will have to be done when we do augmentation. How big should the patient go? And what's the optimal approach into doing the breast augmentation? Should it be from the inframammary fold here? Can it be in the axillary area? Something like that. So this can be discussed more with your plastic surgeon. What is the optimal uh, uh, breast reconstruction options or breast augmentation options for you? Facial feminization surgery would, as I've mentioned earlier, the difference between the face of a male and a female were not really from with the skeletal structure of the skull. So usually when we do feminization surgery, what we do is we do forehead contouring. So we can do different procedures. We can shave the bone. We can add fat or do fat grafting. Eyebrow reshaping can just be done by microblading and then by doing brow lift, probably just to increase the the position of the eyebrows. Rhinoplasty, we can say that female noses are thinner and are more upturned as compared to males. So we do rhinoplasty also. Chin and jaw contouring, since the male face is more square, then we can shave part of the jaw, the angle, to make it more in a V configuration. And then the chin, we can put some more implants to make it more narrow and more feminine. And we do a tracheal shave for the Adam's apple. We can also do liposuction, hip lipofilling, and Brazilian butt lift. So we know that for a female, there is the narrowest part of the torso would be at the hip, and it will widen to the waist with a very less prominent hip depression. So we can see here in the example that on the left, you can see that the patient has a very marked hip depression. But after the procedure, you can see that with lipofilling or fat transfer, we put fat on this lateral aspect of the hip. Now it looks like a nice curve and more feminine. Hairline feminization is also can be done. We can do it via surgery. We can transpose or we can do an incision so that we can bring down the hairline. We can do hair transplant instead of doing a more aggressive surgery, or we can just do tattooing or microblading so that it may appear as if the patient has a hairline that is nearer to the brow. Now, sex reassignment surgery is the ultimate surgery that will be done for patients undergoing transition. It needs 2 referrals. The criteria for doing this sex reassignment surgery would be to have persistent, well-documented gender dysphoria, the capacity to make a fully informed decision and to consent for treatment, the age of majority in a given country. Now, if there are significant medical or mental health concerns, they should be well controlled, and the patient should have 12 continuous months of hormone therapy as appropriate, and 12 continuous months of living in a gender role that is congruent with the gender identity. So this is just an example of a sex reassignment surgery. This is just the before and after, but in general, this is what we do when we do the surgery. We first excise the scrotal and perineal skin, and then we do the orchiectomy, we remove the testis, and we deglove the penis here, deglove the penis here, and then after degloving, we do create a neo-vagina using the penile skin. Then after that, we trim the head and then make it a neoclitoris going up here. And then we spatulate the urethra and use the urethral mucosa to line the clitoral hood and the inner labia. And then we form the neovaginal graft using the inverted penile skin and scrotal skin here. And then vulvuloplasty, the remaining skin, we make as if like a vagina. Now, is there an increased suicide risk for patients who underwent SRS? There are different studies that cited increased risk for suicide, but this is actually for patients who had surgeries in 1970s or 80s. Now, there has been a leap in the psychiatric, medical, and surgical interventions available for trans women who opt to undergo transitioning or SRS. So overall, studies have been reporting a steady improvement in outcomes as the field becomes more advanced. Outcome research has mainly focused on the outcomes of sex reassignment surgery. In current practice, there is a range of identity, role, and physical adaptations that could use additional follow-up or outcome research. That is all for the first part of my talk. Thank you very much, and I will be happy to answer your questions later. Thank you.